Hello everyone. Today we'll be talking about Vernakalant. So, Vernakalant is a newer drug, which is an antiarrhythmic drug, which has been recently approved for the pharmacological cardioversion in case of recent onset atrial fibrillation. So, patient with recent onset atrial fibrillation, there are two options for them which we can choose. Either we can choose a rate control therapy or rhythm control strategy. So atrial fibrillation patients generally have a irregular pattern of irregular contraction, that is irregular rhythm, with a increased rate is there. So based on the presentation, we can either choose a rate control or rhythm control strategy. In rhythm control strategy, there are two options. That is, one is we can choose electric cardioversion, or you can choose a pharmacological cardioversion. Vernakalant is the one which comes under the pharmacological agent, and it is being accepted in European Society of Cardiology 2016 guidelines as a drug for pharmacological cardioversion along with flecainide, amiodarone, and propofol. So why it is important is that, as we all know, atrial fibrillation is the most common clinical arrhythmia, which affects at least 1 to 2% of the population. Its prevalence increases with age, with 5% of people aged over 65 years develop atrial fibrillation, and after the age of 75 years, approximately 8% of a patient develops atrial fibrillation. So in patients with atrial fibrillation, so first thing what you need to see is whether patient is hemodynamically stable or unstable. In case of hemodynamically instability, there is no other option. First choice is electrical cardioversion, that is by giving a direct cardioversion or shock. If hemodynamic instability is not there, that is patient is hemodynamically stable, then we have a choice of either elective cardioversion or you can do a pharmacological cardioversion. Pharmacological cardioversion based on if patient has reduced ejection fraction or significant aortic stenosis, amiodarone is a drug of choice. In patients with coronary artery disease with moderate heart failure with reduced ejection fraction, we can use either Vernakalant or amiodarone. But amiodarone is the first drug of choice. Other drugs are flecainide, dibutylide, propofol. So Vernakalant, how does it act? Mechanism is that it is an atrial selective compound, and it blocks both the potassium and sodium ion channels, and it blocks in all phases of atrial action potential. So action potentials starts with the depolarization phase, and this depolarization starting phase involves because of rapid sodium influx, and then the repolarization phase starting from the transient potassium channel, and the stabilized plateau phase because of calcium and potassium, and then the rapid the repolarization phase is by the potassium. So it blocks both the sodium and potassium channel. And Vernakalant is unique in that it has affinity for activated sodium channel as the heart rate increases. So more is the heart rate, more will be the affinity to the sodium channel, and it only causes mild QT prolongation. The pharmacokinetic profile of Vernakalant demonstrates that it has a very short half-life, so therefore it has very less like chances of drug interactions, and it is mainly metabolized in the liver, and it has a half-life of about 3 hours. And in patients with poor metabolizer, it may have a half-life of about 8 hours. Peak plasma concentrations are evident at the end of 10-minute infusion, but fall rapidly at the end of infusion. So Vernakalant is contraindicated in any patient with a systolic BP of less than 100, patient with severe aortic stenosis, or patient with New York Heart Association classification 3 or 4, acute coronary syndrome within the last 30 days, and patient with a prolonged QT prolongation of more than 440 milliseconds are the contraindications for Vernakalant. So Vernakalant should also be avoided when intravenous class 1 or class 3 antiarrhythmic drugs has been administered within the last previous 4 hours. So these are the class 1 and class 3 groups, as you can see here. And prior to the administration, patients should be adequately hydrated with a normal potassium level. It is also not recommended in patients with left ventricular ejection fraction of less than 35%, hypertrophic obstructive cardiomyopathy, restrictive cardiomyopathy, in advanced hepatic impairment, because it is metabolized basically in the liver. Advanced hepatic failure, it should not be used. And clinically meaningful valvular stenosis, if it is there, that is aortic stenosis, also it is not used. What are the side effects is that it causes taste disturbances, sneezing, paresthesias, nausea, which are the main side effects. And it has been seen because of the effects on the sodium channels in the central nervous system. Vernakalant is administered. The administration way is administered intravenously as a weight calculated dose and infused over 10 minutes. So suppose the patient has to be carefully monitored, and in 15 minutes, if the AF has not reverted, the rhythm has not changed, then you can repeat the infusion with a slightly lower dose. And it all should be given in a very suitable environment where you should be ready with a defibrillation. And ideally, you should, prior to giving Vernakalant, an echocardiogram should be done to look for any structural contraindications, as we have already discussed, that is EF of less than 35% and severe aortic stenosis and hypertrophic or restrictive cardiomyopathy should not be given. An electrocardiogram in AF should be taken prior and after cardioversion. If it is successful, then also you should take another. So reference has been taken from this article. Hope I was clear in Vernakalant. If you like my video, do share and do subscribe to my channel. Thank you.